All right. Hi, everyone. Welcome back. We greatly appreciate your active participation, both online and in person here at UBC today. My name is April Goulin. I'm a nurse immunization practice consultant with the Yukon Immunization Program, and I'll be facilitating this session. Our session focusing on new vaccines and new schedules will feature presentations by Dr. Jim Kellner on the pneumococcal conjugate vaccines, followed by Dr. Gina Ogilvie presenting on the HPV vaccine, and finally Dr. Danuta Skowronski presenting on the RSV vaccine. There will be a combined question and answer period following Dr. Skowronski's presentation, and we encourage all of our participants to use Slido to submit and upvote questions, which can be accessed using the QR code on your program. Now, please join me in welcoming Dr. Jim Kellner, a specialist in pediatric infectious diseases at Alberta Children's Hospital, who will be speaking on the new pneumococcal conjugate vaccine.
Well, good afternoon, everybody. It's a real pleasure to be here, and I realize these next three sessions are going to be a bit rapid fire, so I'll get right into it. So I come from Calgary, and in Calgary, this is land acknowledgement that I like to use, so I just want to share this with you from the other side of the Rockies. I'd like to acknowledge and pay tribute to the traditional territories of the people of Treaty 7, located in the heart of southern Alberta, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nation, and the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations, and as well the City of Calgary is home to the Métis Nation of Alberta, Districts 5 and 6. These are my disclosures. I've participated as an investigator on contract vaccine clinical trials supported by Merck, Moderna, and GSK, and epidemiology studies supported by Pfizer. I'm also a member of the NACI Pneumococcal Working Group and a longtime member of the Alberta Advisory Committee on Immunizations. So the objectives in the next not very many minutes are going to be to look at just a bit about the current trends in serious pneumococcal disease across Canada, describe the new PCV 15-valent pneumococcal conjugate vaccine, and the PCV 20 vaccines, both of which have been tested and trialed in children and adults and have been licensed in Canada and have recent NACI recommendations for their use. So they're coming your way very soon. And then describe the updated NACI recommendations for pneumococcal vaccines at all ages. So a reminder about the burden of pneumococcal disease, a really important bacterial pathogen worldwide. And when we think about measuring the burden of pneumococcal disease, we think about the most serious forms. That's what's most readily measured. So at the top of this pyramid shown here, invasive pneumococcal disease, which invades normally sterile blood or normally sterile body cavities, cause pneumonia, meningitis, and sometimes death. But by far, the burden of disease of the pneumococcus is with non-invasive disease, especially pneumonia and then otitis media, and those things add up to a huge burden of disease across the world. And then at the bottom here, not disease, but carriage is an important thing to consider, nasopharyngeal carriage, because this germ, the strep pneumo, transmits asymptomatically from person to person, especially child to child, very readily. And one of the things we count on vaccines to do is to reduce that chain of transmission, and so we count on a big indirect effect of vaccinating children to prevent disease in adults. And so we'll talk about that just a bit. Okay, and this is a reminder that pneumococcal disease, invasive pneumococcal disease, is a bimodal disease by age. And this is Canadian data showing by age group the bimodal distribution. So on the left there, young infants and young children, a peak of illness, and then over the age of 60, another peak of illness that comes and extends to the later decades of life. And this is seen everywhere. Also a reminder that not everybody pays attention to, and this is from some of our own research data in Calgary looking at the mortality. So in 2024, if you look at invasive pneumococcal disease, it's not an antibiotic resistance problem. It's a problem of people getting it who are very frail. And then as well, still the pathogens are bad, whether or not if they get it, it can be prevented by vaccines. But you still end up with high mortality rates. So young adults, 10% more case 30-day mortality, 13% over 65, and over 85, 25%. So that's in modern times. It still causes very significant mortality. This is also Canadian data coming from a new NACI statement that is awaiting a link to be online. But by age, across the x-axis on the bottom is years. You can't read it, I realize that, but from 2001 to 2021. And then different age groups with the different lines. And the point of this slide is to show on the right side of the slide there, in 2020, there was a huge drop in invasive pneumococcal disease. So it was one of these infections that, with the restrictions and distancing that occurred at the beginning of the pandemic, you saw a big drop in disease. And then this just goes to 2021, where it was still low disease, but maybe starting signs of coming back up. So that's from Canadian data. And then just looking at our data from Calgary, and this is now summarized just by all ages together from 2008 until 2023. And in the box on the right, I just want to show that while there was a big drop in 2020 and 2021 in disease, the rebound in disease in 2022 and to the end of 2023 was huge. And so we're seeing invasive pneumococcal disease at all ages at levels that haven't been seen since before the pediatric vaccines were introduced. And so a real loss of benefit of indirect effect in adults especially, and then even a rise in children. And although vaccines have been caught up, there's been disease. Okay, so a reminder of who's at risk for pneumococcal disease. It's a long list of people who are at particular risk for pneumococcal disease. Those with non-immune compromising and immune compromising health conditions, as well as other behavioral and living condition factors that influence. Some are bigger risks than others, and I just highlighted in yellow there hematopoietic stem cell transplant because there's some particular recommendations for in the new NACI recommendations for that, but lots of other risk conditions that increase the risk of invasive pneumococcal disease. So how well are the programs working? And I could go on, that could be a long presentation, but just really a few seconds to talk about it here. And so this pretty busy text slide highlights what we know in Canada and in most of the world really about successes and gaps with pneumococcal vaccines. Success is that there's very high direct effectiveness in vaccine recipients. So children who have received pneumococcal conjugate vaccines, and then as well you have good indirect or herd benefit in those who are exposed to people who have been vaccinated. It's good but not great. And so that's good because the vaccine serotypes have gone way down, but there's over 100 known serotypes of strep pneumo. And so in a way, it's a bit of a thing where there's always going to be a problem if you're trying to get at the main serotypes causing disease, because there's serotype replacement from other serotypes that can come in and cause disease. And that's what we see a fair bit of. And so as well, the polysaccharide vaccines, which have been largely forgotten, they do have some benefit to prevent invasive pneumococcal disease, less benefit against pneumonia, and the duration of benefit is limited. Young children, missing the Y there, on balance, are very well protected, other ages less so. And so some of the gaps have been shown from data from the Canadian Immunization Guide and the Canada 2025 vaccine coverage goals, which has some really cool stuff. I hadn't spent that much time on that site before this, but overall, children are pretty well vaccinated, and there's been an effort to catch up. In 2019 across the country, about 85% of children had 3 or 4 doses by 2 years of age. At risk, young and middle-aged adults, however, only about a quarter had had at least 1 dose of a pneumococcal vaccine, polysaccharide or conjugate vaccine. And then adults over 65 in 2020, just over half have had at least 1 dose of vaccine. So not doing nearly as well for adult delivery of vaccine. So new approaches to vaccine development. There are a lot of things going on in work to develop universal vaccines and the like, but none of those are sort of close to being used. And so for now, it's chasing serotypes. And so what this figure from the new NACI guideline shows, in the top 2 rows there, is the 10-valent and 13-valent vaccines that are used in Canada right now. And then the next 2 rows, PCV 15 with the 2 blue boxes that are the 2 additional serotypes in the 15-valent, and then the PCV 20, the 20-valent vaccine, the 7 additional, including the 5 unique ones there. And then at the bottom is the 23-valent polysaccharide vaccine. So it's all about serotypes. So how much of a difference are these 2 or 7 more serotypes going to make? So there hadn't been a new update from NACI on pneumococcal disease since 2016, but since in 2023 and into this year, not one, not two, but 3 new NACI recommendations. So for your reading pleasure, there's links to them, these slides, and can have a look at, but that have come out in the last year and a bit. So I'm just going to highlight ever so briefly in the time here to stay on time. This is what it's been for the last 10 years, is the 13-valent vaccine, the main conjugate vaccine used in children. PCV10 is licensed and used just in Quebec, but given in 3 or 4 dose schedules, 4 dose schedules for high-risk children and given to adults as well. And then the 23-valent is still used in high-risk young adults and adults, and that's how it's been for quite a while. Now, the first of the recommendations that came out last year were that we should actually look at either reducing the role of the 23-valent vaccine or replacing it. And so the thing about the 15 and 20-valent vaccines, and Carrie and I were just talking about this in the break, part of the challenge is with the clinical trials that have been done, none of them have been looking at clinical outcomes so far. They've only looked at the serologic outcomes. What's the antibody response in the people who receive the vaccines? And so you don't know for sure how they're going to be in clinical use so far. And when you compare these new vaccines to PCV13, the existing vaccine, the response to the overlapping serotypes in those who get the 13-valent versus the 15 or the 20 is a little bit lower on average, but it's still above what you need, but a little bit lower on average. And so it makes people a little concerned about how well it's going to work. And then as well, cost. And the thoughts are that the 15-valent is going to cost less than the 20-valent. How much of a difference that's actually going to be, don't know. But if you look at disease, of the disease that's caused right now by serotype, you get an additional 15% coverage with the PCV15, and on top of that, another 25% coverage with the PCV20. So you get a lot more coverage. But the recommendations as of last year for NACI level for adult vaccination, so everybody over 65 and anybody in between who gets it, is to replace the 23-valent vaccine with PCV20, or give the 15-valent and then give a dose of the 23-valent. So for those of you who are delivering vaccines and in charge of programs doing it, I apologize on behalf of the NACI working group for coming up with these kind of recommendations, but it's going to be complicated for a while. And then there's some other specific recommendations for special groups I won't get into in the interest of time. And so then the new recommendations, and these NACI recommendations for children, routine use in children, have been circulating freely, non-confidentially circulating for several months now, but there's not yet, and it says at the bottom, there's not yet a link because they're not on the NACI website or the Canadian Immunization Guide site yet, so, but they will be soon, and if anybody wants a copy and they don't have it, I can send it to them, but it is freely circulating. But here, the recommendations for children then is to replace the 13-valent or a couple of doses of the 10-valent in Quebec with either the 15 or the 20-valent vaccine for otherwise healthy children. For children at increased risk, it should be the 20-valent vaccine, and in a 3 or 4 dose program, and 4 doses for those at higher risk. So a little bit complicated in terms of the recommendations, but this is again based on uncertainty of just how well they're going to work. They're not going to be worse off, but how much better are they going to be, and at what cost are they going to be better? And so there's some other special recommendations there. So in conclusion then, with this time, oh yeah, I have some conclusions. I don't have no conclusions, but I always have something to suggest. Okay, number 1, pneumococcal infections still cause high disease burden globally, especially in children and older adults, and then those with specific health conditions and other risk factors. And we didn't get into that too much, but polyvalent polysaccharide vaccines, both plain polysaccharide and the protein conjugate, are highly effective globally against vaccine serotype infections, but their benefits are partially offset by serotype replacement. Didn't get into that too much, but just reminded you of that. And the 2 expanded valency PCVs, 15 and 20, are now approved and recommended for use in Canada and will be coming to a health unit near you in 2024. It's hard to imagine not. And PCV13 and PCV10 will no longer be there, and maybe 23-valent will no longer be there. And yeah, higher valency PCVs may or soon will replace PPSV 23. So with that, I'll say thank you very much for your attention and look forward to the other presentations and discussions.